The self-inflating bag inflates automatically without a compressed gas source. It remains inflated at all times unless being squeezed. Peak inspiratory pressure, or peak inflation pressure, is controlled by how hard the bag is squeezed. Positive end expiratory pressure, or PEEP, can be administered only if an additional valve is attached to the self-inflating bag. There are 7 basic parts to a self-inflating bag: oxygen inlet, oxygen reservoir, air inlet and attachment site for oxygen reservoir, pressure gauge or pressure gauge attachment site, pressure release or pop-off valve, valve assembly, and patient outlet. Advantages of the self-inflating bag: will always refill after being squeezed, even with no compressed gas source. Pressure release valve makes overinflation less likely. Disadvantages of the self-inflating bag: will inflate even if there is not a seal between the mask and the patient's face. Requires oxygen reservoir to provide high concentration of oxygen. Cannot be used to deliver free-flow oxygen reliably through the mask. Cannot be used to deliver continuous positive airway pressure, CPAP, and can deliver positive end expiratory pressure, PEEP, only when a PEEP valve is attached. Free-flow oxygen cannot be given reliably by a self-inflating bag. A bag must be squeezed for reliable oxygen delivery, so a separate setup may be necessary to deliver free-flow oxygen. If a self-inflating bag is connected to a 100% oxygen source, the oxygen enters the bag through tubing connected between an oxygen source and the oxygen inlet port on the bag. However, each time the bag reinflates after being squeezed, air, oxygen concentration 21%, is drawn into the bag through the air inlet. The air dilutes the concentration of oxygen in the bag. Therefore, even though you may have 100% oxygen flowing through the oxygen inlet, it is diluted by the air that enters each time the bag reinflates. As a result, the concentration of oxygen actually received by the patient is reduced, and the exact concentration is unpredictable. Concentrations of oxygen higher than is present in room air are most reliably delivered by using a blender and an oxygen reservoir. An oxygen reservoir is an appliance that can be placed over the bag's air inlet. The reservoir allows the gas coming from the blender to collect at the inlet, thus preventing the gas from the blender from being diluted with room air. However, the flow of oxygen is delivered reliably to the patient only when the bag is squeezed. The flow-inflating bag collapses like a deflated balloon when not in use. It inflates only when a gas source is forced into the bag and the opening of the bag is sealed, as when the mask is placed tightly on a baby's face, or when the baby has been intubated and the bag is attached to the endotracheal tube. Peak inspiratory pressure is controlled by the flow rate of incoming gas, adjustment of the flow control valve, and how hard the bag is squeezed. There are 4 parts to a flow-inflating bag: flow control valve, oxygen inlet from blender, pressure gauge attachment site, and patient outlet. Advantages of the flow-inflating bag: can deliver up to 100% oxygen, depending on the source. Easy to determine when there is a seal on the patient's face. Can be used to deliver free-flow oxygen at concentrations up to 100%, depending on the source. Disadvantages of the flow-inflating bag: requires a tight seal between the mask and the patient's face to remain inflated. Requires a gas source to inflate. Requires the use of a pressure gauge to monitor pressure being delivered with each breath. A flow inflating bag can be used to deliver free flow oxygen. The mask should be placed loosely on the face, allowing some gas to escape around the edges. If the mask is held tightly to the face, pressure will build up in the bag and be transmitted to the newborn's lungs in the form of CPAP or PEEP. If a flow-inflating bag is used, the bag should not inflate when used to provide free-flow oxygen. An inflated bag indicates that the mask is tight against the face and positive pressure is being provided. Flow-inflating bags usually have a site for attaching a pressure gauge. The attachment site usually is close to the patient outlet. The pressure gauge registers the amount of pressure you are using to ventilate the newborn. If your flow-inflating bag has a connecting site for a pressure gauge, a gauge must be attached to the site, or the attachment site must be occluded with a plug. If not, the site will be a source of leak, and the bag will not inflate properly. The T-piece resuscitator is flow-controlled and pressure-limited. Like the flow-inflating bag, this device requires a compressed gas source. Peak inspiratory pressure and positive end expiratory pressure, PEEP or CPAP, if desired, are set manually with adjustable controls. Breaths are delivered when the operator alternately occludes and opens the aperture on the device connected to the mask or endotracheal tube. There are 6 parts to a flow-controlled and pressure-limited T-piece resuscitator: gas inlet, patient gas outlet, peak inspiratory pressure, patient T-piece with positive end expiratory pressure, PEEP cap, circuit pressure gauge, and maximum pressure relief control. Advantages of the T-piece resuscitator: consistent pressure, reliable control of peak inspiratory pressure and positive end expiratory pressure, reliable delivery of 100% oxygen. Operator does not become fatigued from bagging. Disadvantages of the T-piece resuscitator: requires compressed gas supply, requires pressures to be set prior to use, changing inflation pressure during resuscitation is more difficult, risk of prolonged inspiratory time. Before birth and throughout intrauterine development, the fetus lives in an environment where the blood oxygen saturation is consistently at approximately 60%. After the first breath of room air is taken and the umbilical cord is cut, the normal newborn delivered at term gradually increases his or her oxygen saturation to greater than 90%. However, even healthy newborns may take 10 minutes or longer to reach this normal extrauterine saturation. Once the mask is positioned, an airtight seal can be formed by using light downward pressure on the rim of the mask, or gently squeezing the mandible up toward the mask. During positive pressure ventilation with a mask, gas is forced into the oropharynx, where it can enter both the trachea and the esophagus. Proper positioning of the newborn will transmit most of the air into the trachea and the lungs. Gas forced into the stomach interferes with ventilation, where it puts upward pressure on the diaphragm, preventing full expansion of the lungs. This may also cause regurgitation of gastric contents, which may then be aspirated into the lungs during positive pressure ventilation. The heart lies in the chest between the lower third of the sternum and the spine. Compressing the sternum compresses the heart and increases the pressure in the chest, causing blood to be pumped into the arteries. When pressure on the sternum is released, blood enters the heart from the veins. Gently open the baby's mouth and press the cuff end of the device, with the open side of the cuff facing anterior, against the baby's hard palate. Flatten the back side of the mask against the baby's palate with your index finger just above the cuff. Ensure that the tip of the mask remains flat and does not curl backward on itself. Using your index finger, gently guide the device along the contours of the baby's hard palate toward the back of the throat. Do not use force. Use a smooth movement to guide the mask past the tongue and into the hypopharynx until you feel resistance. The baby's neck should be slightly extended, but not overextended, into the sniffing position to maintain an open airway. One way to accomplish this is to place a rolled towel or small blanket under the shoulders. Open the baby's mouth. You may need to use your right index finger to make it easier to insert the laryngoscope. Slide the laryngoscope blade over the right side of the tongue and toward the midline, pushing the tongue to the left side of the mouth. Then, advance the blade until the tip lies in the vallecula just beyond the base of the tongue. Lift the blade slightly, thus lifting the tongue out of the way to expose the pharyngeal area. When lifting the blade, raise the entire blade by pulling up in the direction the handle is pointing. Do not elevate the tip of the blade by using a rocking motion and pulling the handle toward you. Sometimes, pressure applied to the cricoid, which is the cartilage covering the larynx, helps to bring the glottis into view. This is accomplished by using the fourth or fifth finger of the left hand or by asking an assistant to apply the pressure. If the tube is inserted too far, it will usually pass into the right main bronchus. When you insert the tube, it's important to watch the vocal cord guide on the tube and stop advancing the tube as soon as the vocal cord guide reaches the cords. The carbon dioxide detector will change color during exhalation if the endotracheal tube is in the trachea.